We can get started. We can get started whenever you're ready. And as people come into the waiting room, I'll let them in, but we can get started, I think.
Okay. Well, thank you very much, Amanda. Thank you for all your technological wizardry and supporting this Lunch and Learn series. And I would like to welcome you all this afternoon to our inaugural offering of our Kawartha Lakes Haliburton Ontario Health Team Lunch and Learn series. The objective of this series is really to broaden the conversation and awareness of the work being done as it relates to the strategic priorities and directions of our Ontario Health Team. If you could advance the slide, please. So I won't spend a whole lot of time on this. This is my socialization slide of what our Ontario Health Team plan is. We are a collaboration of health and social service providers, advancing integrated care with an equity lens. And our work, it falls into these three buckets at this point. We are working to advance integrated care through the creation of integrated clinical pathways for congestive heart failure, chronic obstructive pulmonary disease, palliative care, mental health, addictions, substance use health. In tandem, we're working to advance digital health maturity and the ability to share information across multiple settings, both for the public and the providers, as well as increasing our engagement with primary care providers and the community, and it's especially with equity deserving populations. So obviously, palliative care figures into our strategic directions for 2023-2024, and I'm sure it will well into the future. We've just begun our work as an OHT in the palliative care space, but that's not to say there hasn't been a lot of work having been done in palliative care in our OHT region for quite some time. Our current work is focusing on doing a current state analysis, understanding the stakeholder environment, mapping pathways, and looking at referral patterns, trying to understand some of the pressure points that our esteemed palliative care providers are facing, such as availability of home care supports, the ability to communicate across multiple service providers, etc. So we begin today with what for many of us around the table will be an intro, and for many of us will also be a refresh of the role that our palliative care community teams play in the palliative care journey for many members in our community. And I'm very pleased to welcome the palliative care community teams from Community Care, City of Kawartha Lakes, and Haliburton Highlands Health Services to share this model of care that is so near and dear to many caregivers and clients alike. So I'll pass the torch over now to Sharon Yeo to start their presentation.
Perfect. Thank you so much, Stephanie. And welcome to everyone that has joined us today. My name is Sharon Yeo. I'm the manager of hospice services for Community Care City of Kawartha Lakes. And I will be here to share the goals for today. We have two goals, really small, to introduce our team members and to offer clarity about the role of palliative care community teams and how to access our services. I'm really excited that we are the first episode of the Lunch and Learn series. And I'm delighted, as I said, I'm delighted to be here. When I get nervous, I say the word delighted, so you can start counting at any time. It's evident from the interest in the presentation that there's an appetite to learn more about palliative care community teams and palliative care in our area. And I'm so excited that you want to learn this, and we'll be able to pass this information on to those who need it. In Kawartha Lakes and Haliburton, there has been and continues to be a strong drive to provide palliative services in our communities, to providing community-based programs, pain and symptom management, and emotional support to clients and their loved ones. For nearly a decade, the palliative care community teams have quietly and diligently operated behind the scenes, working to provide seamless, compassionate, collaborative support to individuals facing life-limiting illness. Their dedication has been unwavering, and their impact is big and also hard to measure. But I can tell you that these teams are well received, and the people who use our services could easily be lost without this service to them. You'll hear from many members of our teams today. This has certainly been a group effort to pull this together. So you will be jumping around to a few folks who are experts in that, are subject matter experts. And it's also my pleasure to introduce the palliative care team for community care City of Kawartha Lakes. And Elaine will follow up from KLH-OHT on her introductions, and that you'll start to see the differences between both of our organizations. Lots of similarities, but there definitely are nuances and differences between us. So in the City of Kawartha Lakes, we have a large geographical area, and Halliburton will say the same. We cover 3,033 square kilometers. We go north to Norland, west to Seabright and Balsover, east to Bobcaygeon and Kinmount, and south to Pontypool. That is a very large area, especially knowing that most of it is rural. We have approximately 80,000 people. Our population is about 80,000, and conservative estimates have us reaching, increasing by 25% in the next 10 years. Just from last year alone, our population has increased by 6%. And I don't mean to be cheeky, but I don't anticipate it 20-somethings move into the area. It will be people that historically will have higher healthcare needs. On our team, we're very lucky. We have Megan Tremblay is our team lead. She is your point of contact when you call here. She has been with the team since its inception. We have 2 navigators on the call. You'll hear from them as well. Sherry Ann Smith and Rosemary Wright combined have over 50 years nursing experience, and both have a passion and expertise in palliative care. Brian Farmer is on the call as well. He is our supportive care counselor. He is a psychotherapist and has been with our team since the beginning, and somehow he managed to not get a speaking part today. We also have a nurse navigator that works out of the Ross, point 4, Kim Rogers. She supports our programs at the Ross. We also have a hospice services team, which includes our volunteers who provide one-to-one support for clients and their loved ones, as well as support illness support groups and volunteers on the palliative care unit at the Ross. We are very unique and thankful that we have an on-call physician group, a group of local physicians. There's 6 local physicians with full practices and 1 hospitalist who make up our 7 doctors who provide support after hours, to provide a one-time admission consult and physician-to-physician support. So you can see right off that we are different from KLH-OHT. We typically have a roster of between 80 and 100 folks. KLH-OHT, I think, has a similar roster with a much smaller team. So they are amazing up there. So I'm going to pass it over to Elaine.
Hi, my name is Elaine Faulkner. And it's my pleasure to introduce the palliative care community team for Halliburton County. And as mentioned, we do serve a large area. We go up to just south of Algonquin Park for the Dorset area. We are serving north of Kinmount, west of Carnarvon. I think there's a song about that, and east of Cardiff. So we cover about 4,000 square kilometers, so quite a large area as well. And from the last census, our population growth, we have seen a 14% growth in the area, with 63% of the people moving to our area over the age of 50. So that speaks for itself. And that's from, I believe, the census done in 2021. So the growth definitely is continuing in our area. So our team, small as it is, consists of a wealth of experience and knowledge. So we have Beth Archibald, who is our patient navigator, and she brings over 30 years of nursing experience to this role and has been doing it full time for over 6.5 years. And then we have Suzanne Van Stone, who is our social worker who provides supportive care, and she's part-time with our team, but a lot of experience, over 25 years, and has been with the team just over 4 years. And we're also supported by many people in our, our community and our team. And there is a hospice coordinator as well who facilitates a grief support group along with other team members. Thanks.
Sorry about that. I thought Suzanne was going to share a bit about the supportive care counselor role, but I will let you know about palliative care. I'm speaking to the choir here. I'm sure many of you are well aware of palliative care. It is a philosophy, an overarching philosophy of care that aims to relieve suffering, looking at the whole person, physical, disease management, psychological, social, spiritual, end of life and disease, death management, and focusing on the client and the family who direct the direction that they'd like their care to go in. Palliative care is not just end of life care. Palliative care is a holistic approach that treats a person with serious illness of any age and in any setting. It can help improve the quality of life, reduce and relieve symptoms, and provide emotional, psychological, social, and spiritual support for the person and their caregivers. Palliative care can be part of the treatment plan at any stage of the serious illness from diagnosis onward, and it does not depend on whether the condition can be cured or not. Palliative care can also help with decision-making, advanced care planning, and grief support. Palliative care sees the person beyond the disease.
What is Palliative Care Community Team, or PCCT? The LIN originally funded 3 of its communities in 2014-2015. Halliburton, Kawartha Lakes, and Scarborough were the first 3 communities to receive their funding. Shortly after, about a year or 2 later, they funded the other 3 communities, Northumberland, Peterborough, and Durham. Although all of our PCCTs are modeled similarly, each is unique to the communities we support. And as Sharon mentioned earlier, you will see that in our presentation, even just between Halliburton and City of Kawartha Lakes, how we uniquely support our communities. However, having said that, the overreaching goal of the PCCTs is to provide support to individuals and families facing a life-limiting illness. We do this from the time someone is rostered with our teams through to post-death and connecting to bereavement supports if desired. Together with the community partners, PCCTs provide eligible individuals and families with access to a suite of holistic health services. It's very much a patient and family-centered approach, and we try to support people where they're at in their journey. And we also try to provide support to our caregivers and loved ones as much as we do those who have been diagnosed with the life-limiting illness. Our PCCTs do this by providing a lot of health system navigation with the navigator nurses, psychosocial and spiritual supports with the supportive care counselors, social workers, and connection to our other hospice services. We work very hard to break down the silos that do unfortunately exist in the community healthcare system. We do this by facilitating communication between providers and connecting services together. In City of Kawartha Lakes, we do offer community rounds that happens every 2 weeks. They're Wednesdays at lunchtime. Other community providers will attend, such as the home care coordinators, palliative care coordinators, paramedicine will attend, the palliative nursing supervisors attend, and at the rounds, we'll discuss mutual patient updates, any challenges that we might be having with our mutual patients to try and brainstorm for better palliative care. Our physicians provide one-time palliative physician consults, and we do offer shared communication. So any support that is provided to our patients from the navigator nurses or on-call physicians, the consults, all of those notes are sent to the patient's primary care provider and any other healthcare provider that's involved in their care.
So when we look at your care team, when we go in, we provide a resource finder to our clients so that they have information in one spot. They can go through it on their own time and they don't have to write things down while we're there. This diagram is a visual we use to help explain the care team. We explain that they're in the middle and all their care is around them to help support them. On the top is family and caregivers, which are extremely important because in the community, they certainly offer a bulk of the support in what's going on. Home and community care services, we utilize them. They're part of the care team. If they have services in place, they'll have a coordinator. An example of when we would link with them ourselves is if nursing's already in there and we go in and there's a safety assessment needed by an occupational therapist, we may contact the coordinator and get those things put into place. They're closest to the government, I always say, and the purse strings, so equipment, nursing, those types of things usually will be funded and supported through there. All of them have usually specialists that are involved as well. The hospitals, in case you're using the Emerge or the Ross, we certainly have a 6-bed unit there as well. Family physician and nurse practitioner, so very important in the support, as especially for us with the shared care model. And then the PCCT certainly provides support through the nurse navigator going in, our on-call physician, the navigators and volunteers, that type of thing. So we all work together and we tell them that that black line underneath is what the PCCT tries to keep connected so that we can keep their services as smooth as possible. So what do? We offer palliative care specialists, pain and symptom management clinics, outpatient and in-home. The CCKL has a 24/7 on-call coverage. There'll be a little more information about that afterwards as well, but we are a shared care model and a shared communication with care partners. And we utilize all care partners to provide the 24/7 support that's there. There is evidence to suggest that early palliative care significantly lessens depression and anxiety. It improves quality of life and it improves the symptom control. Involving us early helps to build a trust and relationship with the client and the family, and some usually helps reduce stress and the overwhelmed feeling when they get into a crisis, as they know they can reach out to us. So it's nice when we can get in there a little bit earlier. The PCCT offers support and consultation for MRPs. We build capacity in families, such as coaching around medication, timing of medication, non-pharmacological symptom management, diet and nutrition needs. And we give them guidance on who to call and when. And we always kind of say, if you're not sure who to call us and we'll help you figure it out. The team has psych and social support for the loved ones, and that's offered through a supportive care counselor. We help facilitate advanced care planning discussions with usually the nurse navigator, and anything more in depth through a supportive care counselor as well. Our journey with the client and family does not end at end of life. We offer grief and bereavement supports whenever it is needed. And Beth, I'm not sure if you have anything you'd like to add that's a little different from ours.
I do. As you've probably noticed in past slides and through some of our discussion already, we are quite differently resourced in Haliburton County, both within the PCCT itself, but also in terms of other health human resources, which poses numerous challenges. As a result, local primary care practitioners provide palliative, symptom management, and end-of-life care to their patients. The healthcare team continues to depend on primary care providers or MRPs for direction and orders. Even those primary care practitioners that are out of region, we have no other option.
Now that we've looked at what we are, we'll have a quick look at what the PCT is not. First off, we're not a crisis response team. It takes time to get services in place, and we want to become part of the client's healthcare team ongoing. We're not in a position to take over client care from the MRP. We are a shared care model, which means that the MRP is our first contact. When there is no MRP, we try to support the best that we can. We are not a MAID coordinator. We support the client's wishes, and if they'd like to pursue MAID as an option, we certainly help get them connected with the proper providers, but it's not part of our role of what we provide. We're not a hospice care center. The hospice is community-based, so it's important to have good connections with the healthcare team to support the best we can in home. And we cannot provide community PSW or nursing care. We can advocate and collaborate with home and community care services. We don't replace the in-home nursing for things like vitals and wound care, that type of thing, but we do try to connect with the nursing services that are in home, because quite often they are our eyes in home.
Next would be, who would be appropriate for our palliative care team? So truly any person living with a life-limiting illness. We're trying to get away from using a PPS. That was kind of the standard before, is that anyone with a palliative performance scale of 30% or less. But we know that someone with that type of a PPS can quickly deteriorate. And as we've mentioned, it's best for us to get in early so we can build capacity and trust, both with the client, their family, and their caregivers. So we like to have you think about the question when you see your client, do you think that they would still be here in a year? And if your answer to that question is, no, I don't think they will be, then they would be an appropriate referral to our team. We take any kind of diagnosis, although it is more difficult for us to support those chronic illnesses that don't have a typical trajectory and can bounce up and down, back and forth, like our COPD, CHF, dementia, Parkinson's, those types of things. Any age. We serve anyone over the age of 18. We have had a couple referrals, I believe, in the past for pediatric that actually never did come onto our team, but we need outside support with pediatric support for that. And the other most important thing of the equation, piece of the equation, is that the client needs to be willing to accept our services and consent to us being involved. And you might ask, why would someone not want our help? And most often, the answer to that is they're already overwhelmed. Whether they're overwhelmed with their diagnosis, whether they're overwhelmed with enough people coming in and out of the house. They may be very private and not want anyone to know. They might think their family will be able to do everything for them and they don't need outside help. And they may not really be coming to terms with the diagnosis that they've been given. So we do really, once we've received a referral, we do need them to consent before we can actually roster them with our team.
Thank you, Rosemary. So if you would like to make a referral to our services, there's many different ways you can do that because we're flexible like that. On the screen there is our original fax referral form, which is easily obtained by either connecting with myself or Beth or whichever PCCT is closest to your area, and we can certainly either fax you a copy or email you a copy. But again, not limited to just receiving our referrals that way. I know lately oncology through our local cancer center has adopted forms through their EPIC system. Often visiting nursing will call on the fly because they're not close to a fax machine, so certainly can take information that way. And of most recent, our organizations have adopted the CareDove system for putting referrals through. There is a link on our website to submit referral that way. It is in its infancy, but certainly we are starting to see some referrals come through. And I believe Stephanie, when I'm done, is going to speak to it with connection to Ocean.
Yep.
So anyone can refer to our services. I've definitely mentioned a lot of healthcare providers. Typically, we do receive our referrals from primary care providers, hospitals, oncology, cancer centers, but again, definitely not limited to. Anyone can refer to our services. A family member can call, case managers, anybody can refer. If you are wanting to make a referral but unsure either appropriateness or location, because geographically where they live, by all means, again, please give a call. We're happy to chat. But we also all work closely together that if I am to receive a referral, say in Beth's jurisdiction, we happily just fax and forward it through to the appropriate PCCT. And finally, I'd just like to sort of reiterate what Rosemary touched on with regards to referrals. When they are received, it does not mean that they are automatically accepted to services. So in the process that will be discussed in the next slide, a referral is received and an intake is done first. So when I connect with somebody, or I know Beth up in Halliburton connects with somebody, the first step is to explain the services that we do offer and obtain consent. So until somebody consents to our services and essentially that initial assessment is completed by the navigator nurse, they are not rostered with our team.
That's over to me then. I just wanted Megan reference the CareDove platform, and that has been adopted by our Ontario Health team as both our public and provider-facing navigation platform. It's built into our KLH-OHT website, so we can accept, they can accept referrals, e-referrals directly from that website. From family members or clients, potential clients. But what's hot off the press at this point that I'd really like to share, this is our first announcement of this, is we have been able to integrate our CareDove platform with the Ocean e-referral network, which is embedded in all of our primary care providers' electronic medical record systems. And so nurse practitioners, family doctors, allied health, interdisciplinary health providers are able to refer directly from their EMR now by doing a search on the Ocean e-referral platform, which seamlessly integrates with the CareDove entry and will land in the palliative care community team inbox. Just that simple. So we're really pleased to be announcing this for the first time today publicly. And yeah, we're very excited about the potential that this platform will hold for all kinds of access issues around community support programs.
We'll talk a little bit about the intake process and a journey with the teams and our clients. It's important to note that step 1 and step 2 would both be done by Beth in Halliburton, as she is a one-person show. So again, referral is received. Meg will call the client caregiver and set up an intake and deem appropriateness of the client. Client will accept our services, and that will mean one of the navigators will go in. And that we try to keep that around 2 weeks. I know on the electronic version of our referral, there is a scale for urgency. And that is because that form is used by all the partners in our LIN. And again, we are not set up for an urgent intake and adding them to our roster. So one of us, the navigators will go out to meet the client and their family. It's about an 1.5 to 2 hour home visit. It is very comprehensive. We do head to toe. We talk about, we do a physical assessment. We talk about their medications, how they're taking their medications they may have lying all over the home that they bring out as we ask about different questions. We talk about symptoms and talk about spiritual aspects, social aspects. What do their social supports look like? How are they managing their activities of daily living? Who's driving them where? How are they getting to and from? Are they marginalized? Is there any supports that we can put in to help them with that? And talk about where they would like to have their end of life, if possible. We like to help keep them on track for that. And explain any other services that could be available to them that they might not be aware of. So home and community care, for example, the nursing, PSW, occupational therapy, physiotherapy, talk about social work, talk about the community paramedic visiting program, as well as treat and refer, and all of those other aspects. After one of us have been in, our notes again will be typed up and shared with their primary care practitioner. Meg also sends a note requesting or letting them know that it's a shared care model and asking if they want our involvement for after hours care. Some physicians do not, and so we like to follow that rule, as well as asking their family physician or primary care provider if it's okay for the CCKL team to send in one of the physicians to do an in-home palliative assessment. And so if they consent to that, then that will also happen in City of Kawartha Lakes. Step 4 is really the meat and potatoes of what we do as navigators and the team. It's the constant follow-up and connection with those clients, addressing their needs. Sherry Ann and I often describe ourselves as their go-to girl. So if they don't know who to call or they just have a question, then they call us, and it's our job to find out, to be able to answer the question or find out where to direct that question for them. Lots of support, lots of emotional support. I find the caregivers and the clients, they just want to hear a human voice and they want to talk with somebody about something. They're very receptive to us doing follow-up phone calls. While we're doing those follow-up phone calls, as they get nearer to end of life, those conversations happen about end of life wishes and where they want to die, and is everything in place, and advanced care planning and DNRs and all that kind of stuff, as well as supports that need to be put in place for that to happen, such as the expected death in the home package, who's going to sign the death certificate if the patient passes away at home, making sure those symptom response kits are in there, and medications and all that kind of stuff. We work very closely with home and community care to try and make sure that the client's journey and their is what they want it to be for end of life. And again, after end of life, we do wrap around and follow up with those bereavement supports and services that are built into our team. Next slide. Any Beth, did you have anything to add to that? No. Okay. Palliative pain and symptom management consult for us here at City of Kawartha Lakes. Again, we are fortunate to have our on-call physicians. We can identify what the gaps are, have a discussion with the client, forward that information to the doctor. Sometimes the doctor goes out into the home visit to see the client in the home and see exactly what needs to be done. Also facilitate those conversations with physicians as well that want to support their own clients and have physician to visit support. And I know that it is very different for Beth up in Haliburton, so I'll let her chat about that.
We do our best to address urgent palliative issues. If the patient is rostered with the local family health team, they will have access to this team during business hours, and I try and facilitate that. If I'm talking to the patient on the phone, I'm on the same electronic medical record. I can send a message directly to the physician and the patient chart about the issue that's arisen. And after hours on-call schedule is provided to me that I can then share with the in-home nursing agencies should urgent palliative issues arise evenings, nights, or weekends. Individuals with out-of-region primary care practitioners will find it more difficult to access after-hours support through their nursing agency, as their primary care practitioners' practice may not offer 24-hour support. And in these cases, a presentation to emerge may be necessary.
Again, our team is very unique that we have a navigator position at our local hospital. She is our eyes and ears in hospital. So one of the lovely things that came out of the EPIC happening at our local hospital is that we are able to create a roster of our clients that appears in EPIC when they are admitted. So it's an easy eyes on to know who's in the hospital. Our navigator can connect with the client and their families, just again to make sure that they know that we have our eyes on them and we know where they're at. She will let us know when they're admitted, discharged, if they pass away, so we can do that follow-up phone call again to the families and just keep that circle nice and tight. We do have a unique agreement with our EMS. A few stars need to align for this to happen. It's called a non-urgent transfer. So should we have a client in the community that needs admitted to the palliative care unit for symptom management or end of life, and they have a bed on the palliative care unit, the nurse navigator in the hospital will find a hospitalist who will accept the patient. And then there will be a non-urgent transfer from home directly to the PCU, which is wonderful because it diverts someone from emerge, as well as it's a nice seamless transfer to get that client directly to a bed on the unit and not to have that hubbub of being in emerge. Again, the stars need to align. We do only have 6 beds, but it is nice when it does happen. Beth, do you have some?
Yes, up here in Halliburton, I monitor the inpatient roster on Epic. It's a little simpler because there's only 15 beds and 1 emergency room, so it's easy to monitor. And I will provide supportive visits during difficult times of transition to PCCT clients while they're in hospital. Additionally, PCCT referrals from the Halliburton Hospital are forwarded frequently while the patient is still an inpatient or even in the emergency room. And I will make every effort to get over and visit the client while they're still there and introduce both PCCT and the PCCT role, get their consent if they are in agreement. And that just eases that transition afterwards. It's not a cold call. When I make that call after they've returned home, they've met me. So it makes it an easier transition to initiate services in the home.
Wow, that was a lot of information to digest in 33 minutes. So I know there will be some questions, and feel free to put questions in the chat box. Thank you, team. You did a great job presenting. We do have a few take-home messages. Palliative care is an approach to care that does not rely solely on specialist teams. We've learned that today. A referral to PCCT is appropriate upon diagnosis of a life-limiting illness. Clients must be prepared to accept support. PCCT and home and community care support services offer complementary support. They're not mutually exclusive. You can see how closely we work with them. We're not a crisis support or a takeover model of care. And I'll add to that, if there's been one person that has come through PCCT, you've seen one person. Every single patient and client and story is so much different than the others. Some people need a thimbleful and some need a drug. Everybody has different needs, and the nurses do a fantastic job of trying to figure out what everybody needs. And I commend them for doing that. We're here for support. Please reach out to us. Reach out for to find out what area that you're in. If you've reached the wrong area, we've said this several times, we will certainly direct you. I often hear Rosemary say, "I'm your girl Friday. If you need anything, give me a shout and I'll figure out where how to help you." We are hoping that after this first episode that we will be invited back sometime and that we can share our grief and bereavement services, because there are some fantastic grief and bereavement services happening in Halliburton and here as well. So hopefully we have had a successful first episode and we'll be invited back. Thank you.
Consider it done, Sharon. Did you want to take some questions now?
Yes, please.
So we've had nothing through the chat come through. If anyone wants to put in any questions now, or you can come off mute as well if you want to ask anything of the team.
Also wanted to share that following the Lunch and Learn, Amanda's graciously offered to send out a fantastic video. CCCKL created a hospice program video. It's so nice. It actually, one of the stars is on here today as Sherry Ann Smith, and it's just a really good video that shows what PCC can do. They help facilitate a couple. He was at end of life, and we're able to pull together a wedding for them before he passed. So we will share that video for everyone to see.
I see, Sabine, you've got a question.
Hello. Yeah, just a question. I mean, if you have any data or numbers, do you receive a significant volume of referrals for individuals with advanced dementia, or do you offer services to individuals who are living with advanced dementia or advanced cognitive impairment?
We do receive, can you hear me? We do receive referrals. We typically are not able to support a dementia diagnosis. It's just been very difficult for us to do. We have found that we don't have the capacity. if there's a lot of caregiver support needed, and we do have a very active local Alzheimer's Society, and we do send folks that way, but it is a hard one for us to, hopefully someday we would be able to, but right now we really struggle with that. I don't have data on the numbers of how many we receive.
In Halliburton County, I do get parachuted in at the very end of life for individuals with dementia who are approaching final weeks.
Thank you.
Just before we jump to the next question, I inadvertently missed an opportunity to speak. So I just want Susan from HHS to jump in and share a little bit about what the supportive care counselor does.
Oh, thank you, Sharon. And actually,
Sorry about that.
It wasn't me. I missed it. I missed jumping in. So I just really quickly wanted to just touch on what we do as supportive care counselors as part of the palliative care community team. So I'm Suzanne. I am a social worker with Halliburton Highlands Health Services, and I know CCKL also has a supportive care counselor, as was listed in the team lists. So really, we're registered professionals, and our role is to provide therapeutic support and assistance to individuals, family members, and their caregivers. Together with the client, we discuss what their self-identified wishes and needs are. And from there, a holistic approach to care is taking, including assistance in understanding and coping with emotional, psychological, social, spiritual, and practical challenges that may arise when experiencing a life-limiting illness and the death of a loved one. So that does include, as we talked about at the very end, bereavement supports. So we're available for information, resources, counseling, advocacy, additional community linkages, and we work alongside the other members of the palliative care team. So just keep us in mind that we're also there to support as well. So thank you. And sorry, I missed my mark earlier.
And Catherine, I see you have your hand up. Did you want to ask your question? You're on mute if you're trying to speak, Catherine.
Oh, hello. Can you hear me?
Yes.
Oh, there we go. Sorry about that. Thank you, Amanda. So first, thanks to Sharon and Elaine and others for the great presentation today. I learned a lot about the PCCT and the invaluable work that you do for the community. I guess, and I might have missed this through the presentation, so I do apologize in advance, but curious to know if clients or patients and or their caregivers are able to provide feedback on the service, and if so, how and when does that happen? You've spoken a lot about sort of, or many people have spoken a lot about sort of the holistic approach that's taken, and so curious to see if there are opportunities for feedback on whether the sort of full needs of individuals are met. Thanks.
I can speak to that a little bit. When the nurse navigators call after the death of a client, they do get feedback then. I don't know if we have a formalized like a survey that we're sending out following involvement in PCCT. I'm sure that's something that we should be looking at as we head into an accreditation, but the nurses do receive that feedback on their follow-up call. Hopefully that helps.
Thanks, Sharon. And we have one more question in the chat, and then we can wrap up. Lynn asked, would something like COPD be considered a life-limiting diagnosis, or does it depend on the stage or severity?
I'm going to pass that over to one of our navigators. They're really good at answering this. Rosemary or Sherry Ann.
Been thrown under the bus. Sorry, I didn't quite hear the question. COPD, is it appropriate to be referred to our team, I believe? So absolutely, we have COPD clients. They tend to be a little tricky only in the respect that sometimes we get parachuted in at the very end because they're rapidly declining, or other times they're on our caseload for quite some time, which is great because we get to build that capacity and the rapport with the clients and see that decline. But absolutely, COPD fits the bill.
And just to add to what Rosemary was saying with the chronic long-term illnesses, That's where we really look at too in taking the referrals for that 1-year question. If you'd be surprised, that person would be alive in a year. It really helps to determine when to refer those long-term chronic illnesses. Again, not exclusive to that, but it does help sort of as a guideline.
Thank you. And then one more question came in. If we can do like a 20-second answer to this. What is the approximate time from referral to nurse navigator contacting the client?
I think, Meg, do you want to take that?
Sure. It can vary depending on the referrals do ebb and flow, but typically it's 2 weeks. Maximum, I'd say about a month, but typically it's 2 to 3 weeks total from time of referral received to a navigator nurse would see them.
Thank you. And if there's any other questions that come up, I will send everyone kind of a follow-up thank you email. You can always just send them to me and I can direct them to the right teams. But we're at time now, so we'll just kind of wrap up the last couple slides. That's great.
So I want to say thank you. Thank you to all of you for all that you do. Your compassion shows through. And thank you for the insight that you've brought in terms of the role of palliative care community teams and how important they are in the journey. We certainly will have you back, Sharon, for grief and bereavement. We'd be happy to do so. This is what we have as our roster of upcoming Lunch and Learn offerings. We'll begin on, I can't see now, Sabine's thing is over my, okay, October 25th, we'll be reviewing our Wellness Connection program, which is variously offered in our by community providers, which is a frailty mitigation program for older adults, and we will be building some evidence and connections to a social prescribing initiative. And then in November, we'll have our session will feature on all community kind of update on the work that we're doing at the OHT. I try to be as succinct as possible, and because there's a lot of it. So I try to give an update for that. So I do hope that you'll come back and lunch with us later. We appreciate you coming, and thank you again to our presenters today.
All right, thank you, everyone.